So as I said before, abstract 5 will be in a later date, so we're going to move on to abstract 6. So it's upper extremity dorsal venous arterialization for no option chronic limb-threatening ischemia by Dr. Lowe and colleagues from Yale and Northwestern.
Good evening. Thank you for the opportunity to present our work. Let me see if I can. We have no financial disclosures. Our patient was a 61-year-old right-handed female who was referred to our institution for chronic right brachial artery thrombosis with ischemic rest pain and dry gangrene. Of note, she has a history of a myeloproliferative disease with a JAK2 mutation and resultant thrombocytosis that was managed with hydroxyurea. 6 months prior to her arrival at our institution, she underwent a right brachial and ulnar artery thrombectomy, which subsequently rethrombosed. On presentation, she had absent right brachial and radial pulses. Her hand was edematous and tender to palpation. Motor and sensation were intact but limited by pain, and she had dry gangrene of the second and third fingertips, as seen in this image. Non-invasive studies demonstrated dampened waveforms in the right forearm and nearly flat waveforms at the right wrist and fingers. There were no audible arterial signals at the right wrist. Transfemoral angiogram demonstrated a diseased brachial artery occluding proximal to the elbow with reconstitution of an interosseous branch leading to a diminutive ulnar artery at the wrist. There was no inline flow to the hand. She was thus taken to the operating room for planned arterial bypass with great saphenous vein. Valvulotomes were passed for non-reversed orientation, and the right distal ulnar artery and palmar arch were then explored. The ulnar artery appeared to be a viable distal target, and the vein graft was then tunneled from axillary artery to ulnar artery. Prior to completion of the distal anastomosis, there was back bleeding from the ulnar artery. However, upon completion, there was a water hammer signal within the graft. Intraoperative angiogram confirmed there was no outflow from the ulnar artery. However, there was interosseous and digital artery filling on delayed imaging. At this point, the interosseous artery was then explored, but found to be sclerotic and narrowed upon making arteriotomy. By this point, all possible arterial targets were deemed unsuitable, and the decision was made to proceed with venous arterialization in an attempt for limb salvage. The cephalic vein at the wrist was dissected free, the saphenous vein graft was retunneled, and prior to the completion of the anastomosis at the cephalic vein, valvulotomy of the distal cephalic vein was performed to the level of the mid-hand. There was a palpable pulse within the graft and a signal within the cephalic vein at the end of the case. She returned to the operating room 2 days later for planned angiogram to re-evaluate the venous outflow. The graft was accessed, and angiogram demonstrated a patent distal bypass anastomosis, indicated by the blue arrow, that primarily filled the forearm veins due to obstruction from distal valves, as indicated by the yellow arrow. Balloon angioplasty was performed across the cephalic vein, and a drug-eluting stent was placed across a large persistent valve that was refractory to balloon angioplasty. Completion angiogram demonstrated a patent arterial bypass supplying the dorsal venous arch. She subsequently underwent planned second and third digit amputations with hand surgery and was discharged home on postoperative day 6 with anticoagulation, antiplatelet therapy, and hydroxyurea. At the time of her 1-month follow-up appointment, her amputation sites were healed and her rest pain was resolved. She is now 2 years post-operation and remains asymptomatic. In summary, upper extremity ischemia is rare but can have significant impact on patient functionality and quality of life. In the setting of no distal arterial targets, venous arterialization may be an option by supplying blood via capillary networks. This case demonstrates a successful upper extremity dorsal venous arterialization with 2-year patency and healed amputation sites. We learned that the axillary artery is an option for inflow source and that the great saphenous vein proved to be a suitable conduit in the setting of long segment arterial disease. This case also showed that thorough lysis of venous valves is critical for patency after dorsal venous arterialization, and that endovascular stenting and balloon angioplasty are options to accomplish this. Finally, a multidisciplinary approach involving hand surgeons can be considered for improved patient outcomes and continuity of care. Thank you for your attention. I'm happy to take any questions.
Dawn Coleman at Duke. What an interesting case. Thanks for bringing this to the meeting. I was hoping you could expand on 2 things for me. The first are the technical components of the procedure. Can you speak a little bit more to the tunnel? And secondarily, to your creation of that distal anastomosis, were microsurgical techniques employed? Did you have struggles with vasospasm, et cetera? And my second question is simply to comment on the medical management for this patient post-op and what treatment and surveillance looked like. Dual antiplatelet therapy, anticoagulation. I presume from your conclusion slides that drug-eluting stent is still patent and your bypass is open. So thanks again.
Sure. So for medical management, the patient is still on anticoagulation. She's on rivaroxaban. She's still on her antiplatelet therapy as well, and she takes hydroxyurea. She follows with hematology for this. In terms of her follow-up, she has been getting arterial ultrasounds, and that did confirm that was patent, and she reports no symptoms. So she actually lives an hour away and follows with another vascular surgeon, but we follow along with her via telephone appointments because travel is difficult for her, and she says she's feeling very well. In terms of the distal anastomosis, hand surgery was there as well for this case, and they did use microsurgical techniques for this procedure. Yeah.
Fascinating case, really, really unique. I guess my question is, how do you know this? How did you know that this was going to work? And how, if you're going to do that, what do you look for to know that that's actually done something beneficial? Is there a change in the finger pressures, or because on the angiogram it didn't look like there was any flow to the digits. So I'm just curious what you do to know that this would have made a difference, or this actually improved the likelihood of the salvage of the amputation.
I'm not sure that we knew that this would work at the time that it was done. I think this was kind of a last-minute last option that was presented with the situation that we had, or that they had. So I don't think it was something that they had known for sure. We knew that the veins, the superficial veins appeared large enough. They did look at the deep veins at the time as well, but those appeared too small. So that's how it ended up being a superficial venous arterialization. In terms of finger pressures and digital filling, I don't know if she's had finger pressures done afterwards, so I'm not entirely sure.
To kind of piggyback on that, how did you time the amputation after the revascularization?
So that was done just a few days afterwards, and that was based on the timing with the hand surgery team. I think at that point, even when she had presented, her fingers had appeared to be demarcated enough, and so the plan was following that, and it was a few days after the second procedure that she had done that she underwent the finger amputations.
Thank you.
Thank you.